Hello everyone, today we'll be discussing diabetes mellitus. So in this video, we're going to cover type 1 diabetes mellitus in details, type 2 diabetes mellitus, and some complications of diabetes. And I also have a separate video for a complication of diabetes, which is diabetic ketoacidosis, so you can watch that after you complete this video. So why is learning about diabetes mellitus important? So basically 1 in 12 people have diabetes, and 1 in 2 people with diabetes do not even know that they have it. And every 7 seconds, 1 person dies from diabetes. So a few more facts is you can have diabetes or pre-diabetes and not know about it. Uncontrolled diabetes can affect every aspect of your health. Diabetes is a significant risk factor for heart disease and stroke. Because diabetes may raise blood cholesterol levels, and stress can increase your blood sugar levels. So what is diabetes mellitus? It is a condition that is characterized by hyperglycemia, which is basically elevated levels of blood glucose, and glycosuria, which is excretion of glucose in urine, and is an endpoint of a few disease processes. The most common type occurring in childhood is type 1 diabetes mellitus, which is caused by autoimmune destruction of the insulin-producing beta cells of the pancreas, leading to permanent insulin deficiency. So basically what happens in type 1 is the cells of the insulin that produce insulin, the cells of the pancreas that produce insulin, they are destroyed, okay? How? By autoimmune process. Type 2 diabetes mellitus results from insulin resistance and relative insulin deficiency. It's usually in the context of exogenous obesity. So basically insulin is being produced, however, it's not enough. Maybe the receptors are not responding to the insulin. So basically type 1, you're able to say pancreas is unable to produce insulin. However, in type 2, you're able to get glucose and insulin is coming to its receptor. However, cell fails to respond to insulin properly. So there is insulin here, however, the cell is unable to respond properly. So definition. So let's talk about diagnosis of diabetes. Mellitus is made based on 4 abnormalities that may need to be confirmed by repeated testing. So basically fasting serum blood glucose concentration should be greater than 126 milligrams per deciliter. A random venous plasma glucose should be greater than or equal to 200 milligrams per deciliter with symptoms of hypoglycemia. And 3, an abnormal oral glucose tolerance test with a 2-hour postprandial serum glucose concentration greater than or equal to 200 milligrams per deciliter. And a HbA1c, which is glycated hemoglobin, greater than 6.5%. And a patient is considered to have impaired fasting glucose if fasting serum glucose concentration is between 100 to 125 milligrams per deciliter, or impaired glucose tolerance if 2-hour plasma glucose following an OGTT is 140 to 199 milligrams per deciliter. So basically classification of diabetes mellitus in children and adolescents. So type 1 insulin dependent. So we've got transient neonatal, which is going to manifest immediately after birth, and it lasts for 1 to 3 months. And there's permanent neonatal, which is due to other pancreatic defects. And there's classic type 1, this is the one that we're going to be discussing, which presents with glycosuria, ketonuria, hyperglycemia, islet cell positive genetic component. And we also have type 2 non-insulin dependent. So we can have secondary type 2 diabetes mellitus, which occurs in cystic fibrosis, hemochromatosis due to some drugs. Then there's adult type classic, which we're also going to discuss. This is associated with obesity, insulin resistance, genetic component. Then we have other types of diabetes, such as gestational diabetes, maturity onset diabetic of youth, or mitochondrial diabetes. So we're going to begin with insulin dependent, which is also known as type 1 diabetes mellitus. Etiology. So diabetes mellitus type 1 results from the autoimmune destruction of insulin-producing beta cells of the pancreas. So in addition to the presence of diabetes susceptibility genes, an unknown environmental insult presumably triggers the autoimmune process. So basically, this destruction of insulin-producing beta cells of the pancreas, okay? The risk for diabetes increases with the number of antibodies that are detected in the serum. When 80 to 90% of the beta cell mass have been destroyed, the remaining beta cell mass is insufficient to maintain euglycemia, which is basically normal blood sugar levels, and clinical manifestation of diabetes result. Clinical manifestations, it's going to present with hyperglycemia. This results when insulin secretory capacity becomes inadequate to enhance peripheral glucose uptake and to suppress hepatic and renal glucose production. Okay. Glycosuria. This occurs when the serum glucose concentration exceeds the renal threshold for glucose reabsorption. So this occurs when blood glucose levels get from 160 to 190 milligrams per deciliter. Glycosuria causes an osmotic diuresis leading to dehydration. Polydypsia. This occurs as the patient attempts to compensate for the excess fluid losses. Weight loss results from the persistent catabolic state and the loss of calories through glycosuria and ketonuria. So the classic presentation of diabetes mellitus type 1 includes polyuria, which is basically increased frequency of urination, polydipsia, which is increased thirst, polyphagia, increased hunger, and weight loss. So outpatient type 1 diabetes mellitus management. So basically management of diabetes type 1 in children requires a comprehensive approach with attention to medical, nutritional, and psychosocial issues. So you need to advise on the medication, the lead most likely will be insulin. Then nutritional, you need to advise them on the diet, and psychosocial, you need to also counsel them, okay? So what are your goals when a patient presents with type 1 diabetes? So you need to maintain blood glucose concentrations as close to normal as possible. Attaining this goal using intensive insulin therapy, it can increase the risk of hypoglycemia. So we're going to talk about the blood sugar levels that you aim for, okay? The goals of therapy differ depending on the age of the patient. So for children that are younger than 5 years old, an appropriate goal is maintenance of blood glucose concentration between 80 and 180 milligrams per deciliter. For school-age children, you aim for 80 to 150 milligrams per deciliter is a reasonable target range. And for adolescents, the goal is between 70 to 130 milligrams per deciliter. And one thing you need to take note is goal of therapy also should take into account other individual characteristics, such as a past history of severe hypoglycemia and the abilities of the patient and the family. Insulin regimens. So there are many types of insulin. They differ in duration of action and time to peak effects. So I've included a table below which we're going to discuss. These insulins can be used in various combinations depending on the need and goals of the individual patient. The most commonly used regimen is that of multiple injections of fast-acting insulin that is given with meals in combination with long-acting basal insulin given at bedtime. So basically with each meal you give fast-acting insulin and then you combine with a long-acting basal insulin which is usually given at bedtime. So after the total daily dose of insulin is determined, 30 to 50% are given as long-acting insulin, and the remainder is given as fast-acting insulin, which is divided according to the need for corrections of high glucose levels and for meals. Then in some countries, we also have pumps that provide a continuous subcutaneous infusion of short-acting insulin. They're also available and are being used by children and adolescents who are highly motivated to achieve tight control. So under insulin regimens, we have Lispro, Aspart, and Glulicin. These are synthetic human insulin analogs in which amino acid alterations result in fast absorption and onset of action. So because of the short duration of action, these are used in combination with long-acting insulin. And I've got Glargine and Detilmir. These are insulin analogs with increased solubility at acidic pH and decreased solubility at physiologic pH. They have a duration of greater than 24 hours and act as a basal insulin. So basically, lispro, and glulisin, these are short-acting. Glargine and determine, these are long-acting. So representative profiles of insulin. So when we talk about very short-acting, we've got lispro, and glulisin. The onset of action is 5 to 15 minutes. Peak action is between 30 to 90 minutes. And the duration of action is 3 to 5 hours. For short-acting regular insulin, we have onset is 30 to 60 minutes, peak action is 2 to 3 hours, and the duration of action is 5 to 8 hours. Then intermediate acting, we've got neutral protein hedge down, which is known as NPH or isofen. Onset is 2 to 4 hours, peak action is 4 to 10 hours, and duration of action is 10 to 16 hours. Then under long acting, we've got glargine. Onset is 2 to 4 hours. There's no peak action, and duration is 20 to 24 hours, which is basically a day. Then determine onset is 2 to 4 hours, peak action is 6 to 14 hours, and duration is 16 to 20 hours. So one thing you need to take note of is the honeymoon period in newly diagnosed type 1 diabetes patients. Okay, so in some patients with new onset of diabetes mellitus type 1, the beta cell mass has not been completely destroyed. Okay, so the remaining functional beta cells seem to recover function with insulin treatment. When this occurs, exogenous insulin requirements decrease. This is a period of stable blood glucose control, often with nearly normal glucose concentrations. This phase of the disease, known as the honeymoon period, usually starts in the first week of therapy, and it often continues for 3 to 6 months and can last 2 years. So I once had a patient who was newly diagnosed with type 1 diabetes. However, after a few weeks, she started presenting with normal blood glucose levels. She didn't really need insulin. So the mother came to ask that should they stop treatment? Well, that's not what they should do. This is when you have to advise the patient that this is a common phenomenon and it occurs in the first week of therapy and it's not going to last long. So it's usually going to be for 3 to 6 months, or it can last maximum 2 years. Okay. So what are the complications of type 1 diabetes mellitus? We've got diabetic retinopathy, diabetic nephropathy, and in children with type 1 diabetes, annual cholesterol measurements and periodic assessments of blood pressure are recommended. Early detection of hypertension and hypercholesterolemia with appropriate intervention can help limit future risk of coronary disease. One special complication that you need to counsel the patient about, you need to advise them, you need to teach them about is hypoglycemia. You need to tell them about the symptoms and what they should do once they feel that way. So hypoglycemia occurs commonly in patients with type 1 diabetes. For patients in adequate or better control, it is expected to occur on average once or twice a week. Severe episodes of hypoglycemia resulting in seizures or coma or requiring assistance from another person occur in 10 to 25%. So basically what they mean, 75 to 90% of patients are able to manage it on their own. Hypoglycemia in patients with type 1 diabetes results from a relative excess of insulin in relation to the serum glucose concentration. So what can lead to the excess of insulin? This excess can be caused by alterations in the dose timing or absorption of insulin, alterations of carbohydrate intake, or changes in insulin sensitivity resulting from activity. Also, it can also arise from defective counter-regulatory responses, also contribute to hypoglycemia. Abnormal glucagon responses to falling serum glucose concentrations develop within the first few years of the disease, and abnormalities in epinephrine release occur after a longer duration. So what are the symptoms of hypoglycemia? These include, so basically the symptoms that arise due to neuroglycopenia, okay? Which is basically our central nervous system or the brain having low level of glucose. So this presents with headache, visual changes, confusion, irritability, or seizures. And the symptoms that result from the catecholamine response present with tremors, tachycardia, diaphoresis, or anxiety. So mild episodes can be treated with administration of rapidly absorbed oral glucose gel or tablets or fruit juices. And more severe episodes that result in seizures or loss of consciousness at home should not be treated with glucagon injection. Should be treated with glucagon injections, and IV glucose should be given in hospital setting. So prognosis, long-term complications of diabetes type 1 include retinopathy, nephropathy, neuropathy, and microvascular disease. Evidence of organ damage caused by hyperglycemia is rare in patients with diabetes of less than 5 to 10 years duration. Clinically apparent disease rarely occurs before 10 to 15 years duration. So that's all about type 1 diabetes. Now go to non-insulin dependent type 2 diabetes mellitus. So the pathophysiology, type 2 diabetes can occur as a result of various pathophysiologic processes. However, the most common form results from peripheral insulin resistance and compensatory hyperinsulinemia, followed by failure of the pancreas to maintain adequate insulin secretion. So basically, there's peripheral insulin resistance and compensatory hyperinsulinemia, which is later followed by failure of the pancreas to maintain adequate insulin secretion. So clinical manifestations. The diagnosis of type 2 diabetes may be suspected on the basis of polyuria, which is increased frequency of urination, and polydypsia, increased thirst, in a background of the metabolic syndrome. So differentiating type 2 diabetes from type 1 diabetes in children on only clinical grounds can be challenging. The possibility of type 2 diabetes should be considered in patients who are obese, have a strong family history of diabetes type 2, have other characteristics of the metabolic syndrome, or have absence of antibodies to beta cell antigens at the time of diagnosis of diabetes. So acanthosis nigricum, this is a dermatologic manifestation of hyperinsulinism and insulin resistance. This presents as hyperkeratotic pigmentation in the nape of the neck and in flexural areas, and is noted as a sign in the metabolic syndrome. Although ketoacidosis occurs far more commonly in type 1 diabetes, it can also occur in patients with type 2 diabetes under conditions of physiologic stress and cannot be used as an absolute differentiating factor. Treatment. So type 2 diabetes is a result of a combination of insulin resistance, relative insulin deficiency, and a secretory beta cell defect. So asymptomatic patients with mildly elevated glucose values, slightly elevated is greater than 126 milligrams per deciliter for fasting, or slightly greater than 200 milligrams per deciliter for random glucose, may be managed initially with lifestyle modifications, including nutrition therapy, diet adjustments, and increased exercise. So basically, what do you begin with? You begin with nutrition therapy, where you need to make dietary adjustments and increase exercise. Exercise has been shown to decrease insulin resistance in most children with new onset and complicated diabetes mellitus type 2. Oral agents are usually the first line of therapy. So only metformin, which is an insulin secretagogue, is approved by the US FDA for use in children. A rare side effect of metformin is lactic acidosis, occurring mainly in patients with compromised renal function. The most common side effect is GI upset. If ketonuria or ketoacidosis occurs, insulin treatment is necessary to first achieve adequate glycemic control, but may be discontinued within weeks with continuation of oral medications. Insulin therapy may be required if adequate glycemic control is not achieved with lifestyle modifications and metformin. Then there are some other drugs that can be used. So we've got sulfonylureas. Example is glibenclamide. Adverse effects are hypoglycemia, weight gain, cardiovascular risk, rash, cholestatic jaundice, bone marrow damage, and photosensitivity. Then meglitinides, we've got repaglinide, for which a side effect is hypoglycemia, sensitivity reactions, GI effects, lactic acidosis. Metformin side effects are GI effects and lactic acidosis. I've got GLP-1 agonist. Example is exenatide. Side effects are GI effects, pancreatitis, risk for cancer, and cardiovascular events. And I've got our DPP4 inhibitors, saxagliptin. Side effects are pancreatitis, risk for cancer, acute hepatitis, and kidney impairment. Then we've got thiazolidine-diones. An example is pioglitazone. Side effects are hepatitis, cardiovascular risk, bladder cancer, water retention, and weight gain. And we've got dual PPAR agonists. Example is saroglitazar. Adverse effects include gastritis, asthenia, and pyrexia. And we've got alpha glucosidase inhibitors. An example is acarbose. Side effects are GI effects and hepatitis. And we've got amylin analogs. An example is pramlintide. Side effects are hypoglycemia and allergy. Then we've got our SGLT2 inhibitors. Side effects are, an example is canagliflozin, and side effects are glycosuria and cardiovascular concern. So because DM2 has a long preclinical course, early diagnosis is possible in subjects at risk who have the metabolic syndrome. Significant lifestyle modifications such as improved eating habits and increased exercise have a role in preventing or decreasing the morbidity of DM type 2. And finally, it is critical to monitor and manage the other components of metabolic syndrome, such as advanced pubertal development, hypertension, hyperlipidemia, and polycystic ovarian syndrome in females. So my reference was Nelson Essentials of Pediatrics, 7th edition. It's all about diabetes mellitus. Thank you.